Female reproductive pathology, a good topic, not too hard, not too easy, but some of the things could be a bit confusing. This I made mostly from the book. What is not from the book has its resource linked below. I think it's very important for you to use official resources, namely your professors and teachers. Please do not disregard the lectures. They are very, very useful.
Question 166. Tumors of the uterine cervix. Pseudotumors. 1. Endocervical polyp. Those are common benign exophytic growths that arise within the endocervical canal. They vary from small sessile bumps to large polypoid masses that may protrude through the cervical os. Histologically, they are composed of a loose fibromyxomatous stroma and are covered by mucus-secreting endocervical glands, often accompanied by inflammation. This is a fancy term to say that there is enlargement of the submucosa, which is covered by those simple columnar epithelium or glandular epithelium that you're already familiar with. Their main significance is that they may be the source of irregular vaginal spotting or bleeding that arouses suspicion of some more ominous lesions. Simple curettage or surgical excision is curative. Let's quickly discuss what a pseudotumor even is. So the definition as given by Professor Dushkova is that those are pathological lesions of different etiologies masquerading as real neoplasms, i.e. those are lesions that look like neoplasms, but their etiology is not that of neoplasms. What is the etiology of a neoplasms? Genetic mutations, as among others, drive proliferation. It also means that their histology is very different because they lack the dysplastic changes that occur after those mutations are accumulated. Which dysplastic changes do we see in malignant cells? You should always remember it's enlarging of the nucleus for the proliferation, it is loss of cell polarity, it is a higher mitotic index. For example, when you look at the tissue, you see more cells undergoing mitosis. Could be enlarged cells as well. Pseudotumors lack dysplastic changes. They lack the anaplastic markers. They are not dedifferentiated cells. Which pseudotumors can we discuss? Cysts, pseudocysts, deposits of pathological material, inflammatory pseudotumors, hyperplastic tissues, and embryonal developmental disturbances. We should keep in mind that some pseudotumors are precancerous, either inherently or just by sheer association. For example, if the cause is a chronic inflammation driving some local mucosal hyperplasia, well, the same inflammation and the same hyperplasia also means that some cells can accumulate mutations and turn dysplastic and turn malignant, right? So it doesn't mean that those are precancerous, but it means that the environment is still driving forward some carcinogenesis. Also, there are things called polyposis, right? So many polyps, for example. If we look at one polyp, you would call it a benign tumor. Some of it would be reactive hyperplasia, right? But if you have many of them, it signifies that there is some inherent genetic susceptibility to having them. And then if you have so many of them, then what we just talked about, that the hyperplasia or the inflammation has a slight chance to turn something into malignant neoplasms. Well, now when you have hundreds of them, then statistically speaking, at least one or two of them will turn malignant. And therefore, we look at the entire situation as a precancerous situation. What is a polyp? A polyp is a local prominence of the mucosa. It could be sessile or pedunculated. It could be a bump, or it could be a stalked prominence. But polyp is also just a descriptive term. It tells you what it looks like. It does not tell you what it is. When you say polyp, is it a benign tumor? Is it a malignant polypoid tumor? Is it just hyperplasia? Who knows? Another pseudotumor in the cervix is the Nabothian cyst. It is a mucinous retention cyst, a mucocella, of cervical glands in the transformation zone. So what happens is when the squamocolumnar junction moves and the squamous metaplasia covers the transformation zone, you could have some aisles of this columnar epithelium stuck in the crypts of the mucosa. And when the squamous metaplasia, which is thicker, occurs at the top of the crypt, it closes the crypts, basically occluding pockets of glandular epithelium. And then the mucinous secretions have nowhere to go, and you have this cystic accumulation there. Cervical carcinoma, mostly presenting around the age of 45. Primary cervical carcinomas are one of four, the most common being squamous cell carcinoma, representing 80% of it. Most of those are high-risk HPV associated. In microscopy, we see nests and tongues of malignant squamous epithelium, either keratinizing or non-keratinizing, which invades the underlying cervical stroma, destroying the basement membrane. It could be exophytic, it could be endophytic, and for staging we use the FIGO system that we will talk about soon. The second most common is adenocarcinoma of the cervix. It develops also from its own precursor lesion called AIS, adenocarcinoma in situ. Also high-risk HPV associated, especially high-risk HPV cervical 18. We see a malignant endocervical epithelium proliferation with large hyperchromatic nuclei and relatively mucin-depleting cytoplasms, resulting in a dark appearance of the glands, as compared to the normal endocervical epithelium. The subtypes here are usual, endometrioid, or mucinous. Next, we can talk about adenosquamous and neuroendocrine carcinomas, which are much rarer, and they are also high-risk HPV associated. Both of them have worse prognosis than SCC because they grow faster and progress faster to invade. Adenosquamous carcinoma is composed of an intermixed malignant glandular and squamous epithelium, and cervical NEC or NECs, neuroendocrine carcinomas, appear similar to small cell lung carcinoma, which is also an NEC of the lung, but they differ in high-risk HPV positivity, which small cell lung carcinoma lack. Cervical carcinoma spread is important. First, it can grow either as an exophytic or infiltrative mass. Exophytic is better for us because we can resect it more easily. What is this infiltration? It's invasion per continuitatem into nearby tissues, meaning that it just grows through the tissues as one big mass. It can go into the urinary bladder, into the ureters, into the rectum, into the vagina, causing very acute symptomatology that you would imagine there, like hydronephrosis in the ureters, like incontinence or retention if it invades the urinary bladder, etc. Distal and local metastasis are via lymphogenic spread, and examples of where it can spread to commonly is the liver, the lungs, bone marrows, but also some others. Please mention the FIGO classification, which stages from 0 to 4 based on depth of invasion. So stage 0 is no invasion, it is a carcinoma in situ. Stage 1, it invades the basement membranes and the submucosa, let's say, but not further, it is confined to the cervix. Stage 2, it extends beyond the cervix minimally. Stage 3, it extends all the way until the pelvic wall. And in stage 4, it extends even beyond that, involving the mucosa of bladder or rectum, or even having already metastatic disseminations to other organs. Note about treatment modalities. Cervical conization is the surgical removal of the area surrounding the transformation zone. The resection is of a cone-shaped tissue, and therefore it is called conization. It is used for diagnostic purposes as part of a biopsy, or for the therapeutic purposes of removing precancerous cells or early-stage cervical cancers. Thank you for listening. See you in the next one.